Good morning, everyone. I'm Ankit Sangvi, Executive Director with Texas Health Institute and co-lead of the Texas Primary Care Consortium. Thank you for joining us today for our first inaugural webinar in what will be an ongoing series starting today, today's webinar will focus on rebuilding the foundation of healthcare, powering high-quality primary care in Texas. And I'm truly excited for the session that we have planned for and our amazing speaker. But before we get started, a few housekeeping items. As previously communicated, this webinar and activity is eligible for CME. And as part of the requirement, I'll read out the statement that this activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education through the joint providership of Houston Methodist and Texas Primary Care Consortium. Houston Methodist is accredited by the ACCME to provide continuing medical education for physicians. Houston Methodist designates this live activity for a maximum of 1.25 AMA PRA Category 1 credits. Physicians should claim only the credit commensurate with the extent of their participation in the activity. Following the webinar, you will receive a session feedback or a webinar feedback survey from Texas Primary Care Consortium, which will also, and following the same, you will receive the session evaluation and instructions from Houston Methodist that will allow you to claim the CME. This is again another slide as part of the CME requirements. We wouldn't be here today without the support of our amazing partners, and precisely I would want to thank our partners at SANA and Texas Academy of Family Physicians for supporting this webinar. But Consortium as a whole is truly grateful for the support and partnership that we have with our amazing partners, including the Texas Academy of Family Physicians, AmeriGroup, SANA, TMF Health Quality Institute, American College of Physicians, the Texas chapter, Path Advantage, and St. David's Foundation. Thank you again for your support. So why the consortium and why today's webinar? For those of you who are joining us for the first time, the consortium is a statewide collaborative initiative that started back in 2013 and with initially the focus on the annual Primary Care and Health Home Summit. And in 2018 is when we recommitted this partnership to a larger mission of advancing primary care in Texas. Our mission is to advance equitable, comprehensive, and sustainable primary care for all Texans. And the initiative is jointly led by our organizations, that is Texas Health Institute and the Texas Medical Home Initiative. Our work as a consortium is guided by our three-pronged strategic framework on educating stakeholders across the spectrum on the value of investing in primary care and its pursuit of lowering cost, improving outcomes, and increasing access and the provider experience, activating our individual strengths, resources, networks, and expertise to raise a collective voice on prioritizing primary care and improving the health of all Texans, and utilizing the consortium as a venue, as a tool and a space for dialogue and action to generate a shift in the healthcare system in Texas through policy and systems change initiatives. And in service of that, I'm excited to introduce our collaborator, my friend and colleague, Dr. Sue Bornstein, Executive Director with the Texas Medical Home Initiative and my co-lead on the Texas Primary Care Consortium, to kick off today's webinar. And before doing that, she'll just give a brief introduction to our amazing speaker, and Dr. Jackson Griggs. Sue, on to you.
Thank you so much, Ankit, and welcome everybody. Ankit shared the Texas Primary Care Collaborative's framework for achieving health systems transformation. And we educate, we activate, and we transform. And today we have the opportunity to learn from a national expert on primary care and to frame the findings of our 2020 report on primary care entitled Making Primary Care Primary, a Prescription for the Health of All Texans in a national and Texas-specific context. It really is an honor and a pleasure to introduce Dr. Jackson Griggs, our guest speaker for this inaugural webinar. Dr. Griggs is a San Antonio native who earned his undergraduate degree at Abilene Christian University and his MD degree from the McGovern School of Medicine at the UT Houston. He trained in family medicine at the Family Health Center, Family Medicine Residency in Waco, where he was elected as chief resident. He joined the faculty there after residency, became the associate program director, and has trained over 150 family physicians. He just doesn't seem old enough to have done that, but okay, we'll go with that. And for those of you that are not familiar with the Family Health Center, it's the federally qualified health center system, really for Waco and its surrounding communities. And it has, I believe, 14 locations. And in 2019, the long-term CEO of Family Health Center, Dr. Roland Gertz, who many of you probably know, retired and Dr. Griggs was selected to succeed him. And I will say that that was out of 270 candidates, and clearly they got the right guy for the job. We invited Dr. Griggs today because he was on the writing committee for the recently released National Academies of Science, Engineering, and Medicine report on primary care. So you could say that he was in the room where it happened. And although we've only known him for a short time, our entire team has been inspired by him, by his knowledge, his passion, his commitment to primary care, and he has been very generous with his time and energy. He's an articulate, thoughtful servant leader, and we're absolutely thrilled to have Dr. Griggs with us. So please join me in welcoming Dr. Griggs.
Thank you, Dr. Bornstein. Ankit, I appreciate both of you so much. Sue, Ankit, this is just a delight for me, and I feel deeply honored to be speaking with this group and to be invited by the Texas Primary Care Consortium. I'm going to share my slides. I've got 30 minutes to share a sort of synopsis of the over 400-page report. And so I'm going to try to do that as efficiently as possible, keeping in mind that really there's no way to capture all of the detail of the work that went into the report in just a few minutes. So I'd encourage everyone here to, at minimum, to take a look at the summary. It's a nice distillation of the work of the paper. And of course, if there's an area that seems to kind of quicken your soul to then go into the chapter that it takes a deeper dive into that content area and to review it. And for the real go-getters, take a weekend and read the whole report. It really reflects a great deal of work by some very, very talented colleagues, and I felt just a tremendous honor to be a part of that group. Let me comment on what a remarkable committee it was, and in particular, just during the pandemic, what thoughtful and resilient leadership we had in our co-chairs, Linda McCauley of Emory and Bob Phillips from the American Board of Family Medicine. The committee included wide expertise from practicing primary care clinicians, policy experts, and academics in critical fields. Our study sponsors included a broad coalition of professional societies, federal agencies, and private foundations. And the charge to the committee was somewhat unusual. It was the task of developing an implementation plan, and we were charged with using the 1996 IOM report on primary care as a starting point. The charge was needed because while the 96 IOM report made comprehensive recommendations to improve primary care, many of those recommendations were never implemented. We started meeting in January 2020, so you can rewind the last decade of pandemic that seems like we've all been living in. This sort of COVID time has expanded out and made it feel like we've been living with this thing for forever. But January 2020, obviously right before the pandemic really took over our lives, we had one meeting in person in DC, and the rest of our meetings were virtual. Our public sessions included sponsors, patient advocacy groups, subject matter experts. We had 3 papers commissioned, and after extensive deliberations and literature review, we made recommendations by consensus. And then the final step, of course, was external peer review. The committee did not relitigate conclusions supporting the value of primary care, but appreciated that literature as the context for the study. We recognized that primary care is the only healthcare component where an increased supply is associated with better population health and more equitable outcomes. Also, through the course of the project, we recognized how COVID-19, how the pandemic amplified the economic, mental health, and social health disparities that ubiquitous primary care would have otherwise minimized. What's more, we saw how the pandemic pushed many primary care practices to the brink of insolvency. And all of this unfolded in the setting of chronically under-resourced primary care in the United States. Primary care, which is inaccessible for large portions of the population, and in a time when visits to primary care were already in decline and with a shrinking workforce. The underfunding of primary care in America is one of the most important contextual elements of the report. OECD countries devote an average of 14% of all healthcare spending to primary care. And in contrast, the United States investment in primary care is only 5% of the overall healthcare spend. The figure here, specifically the green bars, describe how the healthcare investment is divvied up in the United States. By contrast, the yellow bars point to the distribution of health services by visits, revealing the stark discordance between the volume of care delivered and the percent dollar value investment in the United States. Implementing high quality primary care requires the commitment to pay primary care more and differently, given its capacity to improve population health and health equity for all society, not on the basis that it generates short-term returns on investments for payers. Furthermore, high-quality primary care cannot be considered a commodity service whose value needs to be demonstrated in a competitive marketplace, but instead, primary care is a common good that should be promoted by responsible public policy and supported by private sector action. If there is one key message of the report, it's that the committee firmly believes that primary care should be considered a common good, available to all, and sufficiently resourced in the United States. So definitionally, what is the common good we're speaking of? What is high quality primary care? A valuable contribution of the report is an updated definition of primary care, and the committee notes that the definition describes what high quality primary care should be, not necessarily what people universally experience in the United States today. The definition highlights an ideological shift from the provision of services to targeting whole person health. It describes foundational, sustained relationships at its core. What's at the center of high quality primary care? Relationships. It points to the importance of communities and their roles in the provision of high quality primary care. It emphasizes the need for primary care to be equitable. It clarifies that the delivery unit of primary care is interprofessional teams rather than individuals. And it reinforces that primary care is provided in a diversity of settings and modalities. Again, keeping in mind this is an implementation plan, the committee's plan builds on a 3-element implementation strategy. A systems view framework targeting 3 magnitudes of systems where change should take place, accounting for the complexity of the United States healthcare system and its public and private sector actors. Those magnitudes within the system are the macro level, which is government policy level, the meso level, especially healthcare systems, and the micro level, which is the practice level, the delivery level. Second, the plan includes an accountability framework that establishes a structure and process for assessing the adequacy and completeness of implementation activities. And finally, the plan includes a public policy framework that prioritizes government policy to implement high quality primary care consistent with primary care as a common good. The recommended implementation actions of the report are built around 5 key objective areas. And this little rosette that you see on the screen illustrates those 5 areas. The 4 petals of payment, access, workforce, and digital health are held together and surrounded by the element of accountability, and an objective to ensure the work actually gets done. And the committee's 5 objective areas are communicated in simple objective statements. In a moment, we'll look at the recommended actions associated with each of these statements, but first, let's just take these objective statements one at a time. See at the top, number 1, pay for primary care teams to care for people, not doctors to deliver services. Payment reform that supports and encourages high quality primary care is fundamental to the committee's vision for implementing high quality primary care. Number 2, ensure that high quality primary care is available to every individual and family in every community. Everyone in the country should have easy access to high quality primary care that is person-centered, relationship-oriented, and responsive to the needs of the community. Objective 3, train primary care teams where people live and work. When primary care training is interprofessional and is located within community settings, it is more effective at developing the skills that will keep people connected and healthy. 4, the digital health objective, design information technology that serves the patient, family, and interprofessional care team. New health IT standards should prioritize and facilitate high quality primary care. And 5, ensure that high quality primary care is implemented in the United States. This is the accountability objective. Implementing high quality primary care requires clear and meaningful measures of whole person care. It requires ongoing research and leadership in the federal government to assure federal policies support its development. All right, now let's drill a little deeper into the specific action items associated with each objective. And it's probably important to note that what you'll see on the slides as action items are abbreviated version of the committee's recommended actions. So again, I would refer you to the report. Again, even the summary will include the full action items. So under the payment objective, action item 1.1, payers, specifically Medicaid, Medicare, commercial insurers, and self-insured employers should evaluate and disseminate payment models based on the ability of those models to promote the delivery of high quality primary care as defined by the committee, and not on their ability to achieve short-term cost savings. Action 1.2, payers using a fee-for-service payment model for primary care should shift primary care payment toward hybrid reimbursement models, part fee-for-service, part capitated, making those the default method for paying for primary care. For risk-bearing contracts with population-based health and cost accountabilities, such as those with accountable care organizations, payers should assure that sufficient resources and incentives flow to primary care. And those hybrid reimbursement models that I mentioned should have a few key characteristics. They should pay prospectively for interprofessional, integrated, team-based care, including incentives for incorporating non-clinician team members, for example, community health workers. And they should pay for partnerships with community-based organizations. They should be risk-adjusted for medical and social complexity. They should allow for investment in team development, practice transformation, and the infrastructure to design, use, and maintain necessary digital health technology. And finally, they should align with incentives for measuring and improving outcomes for attributed populations. The next action item under the payment objective is that the Centers for Medicare and Medicaid Services should increase the overall portion of spending going to primary care. And they should do this by accelerating efforts to improve the accuracy of the Medicare physician fee schedule by developing better data collection and valuation tools to identify overpriced services, with the goal of increasing payment rates for primary care evaluation and management services by 50% and reducing other service rates to maintain budget neutrality. And CMS should also increase the portion of primary care spending by restoring the relative value scale update committee to the advisory nature as originally intended. And they should do this by developing and relying on additional independent expert panels and evidence derived directly from practices. The dominant fee-for-service payment mechanism in combination with the process CMS uses to set relative prices for primary care and other services continues to devalue and shortchange primary care relative to its population health benefit. And this results in large and widening gaps between primary care and specialty care compensation. A healthcare system oriented more to primary care would result in healthier population with more consistent access to primary care and a more equitable distribution of healthcare. And then the final action under the payment objective pertains specifically to states, that states should implement primary care payment reform by using their authority to facilitate multipayer collaboration on primary care payment and fee schedules. And states should also implement primary care payment reform by measuring and increasing the overall portion of healthcare spending in their state going to primary care. So with that first item, that states should use their authority to facilitate multi-payer collaboration, it's important to note that insurers are forbidden from explicitly coordinating to achieve multi-payer alignment under federal antitrust laws. But state officials can invoke a state action exemption permissible under federal laws, allowing competing insurers to share certain information if actively overseen by state governments. So that's what that action item is getting at, that states should use that authority to facilitate multi-payer collaboration. All right, moving on to the second objective, that of access. The first action item under access is to facilitate an ongoing primary care relationship. All individuals should have the opportunity to have a usual source of primary care. Payers should ask all covered individuals to declare a usual source of primary care annually, and should assign non-responding enrollees using established methods, track this information, and use it for payment and accountability measures. And then health centers, hospitals, and primary care practices should assume and document an ongoing clinical relationship with specifically uninsured people that they are treating. And the second action item is to improve access to high quality primary care for underserved populations and to facilitate empanelment of uninsured people. HHS, enabled by congressional appropriations, should target sustained investment in the creation of new health centers, including federally qualified health centers, lookalikes, and school-based health centers, as well as rural health clinics and Indian health service facilities in federally designated shortage areas. The third action item under access is to improve access to high quality primary care services for Medicaid beneficiaries. CMS should revise and enforce its fee-for-service and managed care access standards for primary care for Medicaid beneficiaries, ensuring them adequate access to primary care as defined by the committee. And CMS should provide technical assistant resources to state Medicaid agencies for implementing and attaining these standards, and measure and publish state performance on these standards. The fourth action item under access, CMS should permanently support the COVID era rule revisions and Medicaid and Medicare benefits interpretations that have facilitated integrated team-based care, enabled more equitable access to telephone and virtual visits. It provided expanded role for interprofessional care team members and eliminated other barriers to high quality primary care. And then the access related action item is that primary care practices should move toward a community-oriented model of primary care by including community members with lived experience in their governance, practice design, and practice delivery, and partnering with community-based organizations. All right, when I was a kid growing up in Abilene, we had a local theater that had, the all like, let's all go to the lobby intermission and have ourselves a treat. I feel like we should do that in the middle of all of our action items here because there's a number of them. So we should have a little stretch break here, but actually I've only got 8 minutes left. So we're going to skip the intermission. I'm just gonna move right ahead. There are 2 action items under the workforce objectives to train primary care teams where people live and work. The first of those action items is that healthcare organizations and local, state, and federal government agencies should expand and diversify the primary care workforce, particularly in federally designated shortage areas, to strengthen interprofessional teams and better align the workforce with the communities they serve. Public and private healthcare organizations should ensure inclusion, support, and training for, this is the extended members of the primary care team, family caregivers, community health workers, and other informal caregivers as members of the primary care team. The Department of Education and HHS should partner to expand educational pipeline models that would encourage and increase opportunities for students who are underrepresented in health professions. HRSA, state and local government and healthcare systems should redesign and implement economic incentives, including loan forgiveness and salary supplements, to ensure that interprofessional care team members, especially those that reflect the diverse needs of the local community, are encouraged to enter primary care in rural and underserved areas. And health systems and organizations should develop a data-driven approach to customizing interprofessional teams to meet the needs of the populations they're serving. The second action item under workforce is that the CMS, the VA, HRSA, and states should redeploy or augment funding to support interprofessional training in community-based primary care practice environments. The revised funding model should be sufficient in size to improve access to primary care and to ensure that training programs can adequately support the primary care pipeline needs of the future. The penultimate objective here is under digital health, is designing information technology that serves the patient, family, and interprofessional care teams. Again, 2 actions under the health IT objective. The first is that the Office of the National Coordinator for Health Information Technology, ONC, and CMS should develop the next phase of digital health, including EHR certification standards, to align with the functions of primary care, to account for the usual user experience of clinicians and patients, to ensure equitable access and use of digital health systems that support equitable care, to include highly usable sense-making functionality, such as automated tools that make sense of data, identify clinically important data, and inform care, that ensure the base products meet certification standards with minimal need for local modification, and that hold health IT vendors and state and national support agencies financially responsible when they fail to achieve benchmarks. And the second action item is that the ONC and CMS should plan for and adopt a comprehensive aggregate patient data system to enable primary care clinicians and interprofessional teams to easily access comprehensive patient data needed to provide whole person care. And then finally, if you'll remember that rosette and the way that accountability held the whole thing together to ensure that work actually gets done. The first action item is that Health and Human Services Secretary should establish a Secretary's Council on Primary Care, a Secretary's Council on Primary Care to coordinate primary care policy, to ensure adequate budgetary resources for such work, to report to Congress and the public on progress, and to hear guidance and recommendations from a primary care advisory committee. So we're there are 2 different things we're talking about. One is a Secretary's Council, and the Secretary's Council will hear guidance and recommendations from a primary care advisory committee. And that primary care advisory committee represents key primary care stakeholders such as patients and certifying boards, professional organizations, healthcare worker organizations, payers, and employers. Now that Secretary's Council, you ask, who are going to be advising HHS Secretary, and the Secretary's Council members should include the CMS Administrator, Director of CMMI, HRSA, the Agency for Healthcare Research and Quality, ARC, the Assistant Secretary for Planning and Evaluation at HHS, and the National Coordinator for the ONC. The second action item in the accountability objective is that the committee recommends HHS form an Office of Primary Care Research at the NIH and prioritize funding of primary care research at ARC via the National Center for Excellence in Primary Care Research. And the third action item is to improve accountability and increase chances of successful implementation. Primary care professional societies and consumer groups at the national and state level should assemble, regularly compile, and disseminate a high-quality primary care implementation scorecard based on the 5 key implementation objectives identified in the report. And the scorecard intends to help track implementation, progress, success, and failures regarding the committee's recommendation. It will also hold actors identified accountable for implementing the steps necessary for high quality primary care. And the committee suggests that measures for this scorecard use a few simple principles, that it uses measures that were previously developed as opposed to proposing new measures, and each should track the committee's objectives either directly or indirectly. It should use few easily understood measures that are understood by the general public and consistent over time, that it should be reliant on data collected regularly, comprehensively, and reliably for producing assessment at relevant scope or geography. And the measures should be available at the national and state levels so as to engage advocates and policymakers. So thank you for hanging in there through all of those action items. I wanted to get, because I know that we have a broad group who are in attendance, I wanted to get all of those action items shared, because now you have the distilled version of that 400 plus page report, at least the best I could do in 30 minutes. So I'm going to hand it now over to Sue, and Sue, take it from here.
Thank you, Jackson. What a fantastic job you did. Not an easy task either. I forget exactly how many hundred pages the full report is, but there's a whole lot of information in it. And you really distilled it in a very approachable, understandable way. And so thank you very much for that. Really appreciate it. I'll get next slide, please.
Yes, Jackson, if you could just stop screen share, so I'll pull this back up. And thank you, Sue. And thanks again. I'll just extend my gratitude and appreciation for sense making the 400.
Sense making.
Okay.
One of Ankit's favorite terms. Yeah.
Wonderful.
Well, thank you. That's the slide I was looking for. Well, when we first had our first conversation with Jackson a couple of weeks ago, maybe a month ago, to talk about this webinar and to talk about the work that he has done with the report from NASEM, I think it's safe to say, I'm not going to speak for him, but I think he would agree with what I'm about to say, and that is that he was struck really by the congruence of our Texas Primary Care Consortium report that we referenced earlier, and the NASEM report. But the more we talked about it and thought about it, we agreed that it really is not that surprising that two different groups of people that looked at the same data would come out with similar conclusions. And in fact, that is really what happened. And as a matter of fact, it's actually kind of striking how similar the conclusions are. And so I wanted to just take a couple of minutes and do sort of a crosswalk. And again, Jackson actually in his generosity did prepare a crosswalk between the NASEM report and the TPCC report. But these are, I think, some of the highlights. And so NASEM, as Jackson said, one of the really, I think, main tenets is to ensure that high quality primary care is available to every individual and every family. In our statement was to strengthen the healthcare safety net, catalyze efforts to address social determinants of health. But I will point out that in our website and in our documents, official documents, the goal of the Primary Care Consortium is to facilitate the collective action to advance equitable, comprehensive, and sustainable primary care for all Texans. So it's there. It may not be right there in that place, but it is actually there. And I think our statement, the first statement, really does reflect our deep concern about the fraying social safety, health, and healthcare safety net, especially in light of the pandemic. I think we were pretty shaky to begin with, and it's pretty clear, whether it's from the Green Center reports that have been tremendously helpful and in a difficult way to watch the evolution of what the pandemic really has done to primary care. So I think our focus on the safety net really has to do to a large extent to our chronic high rate of uninsured in Texas. But again, I think we really are on talking the same language here. The other interesting thing, and I really like the way that you all phrase the pay for primary care teams to care for people, not just doctors. And, some people might say, wow, that's kind of a radical idea. But in fact, I don't think it is a radical. I think it's a logical movement, right? To accepting the fact that primary care physicians, clinicians, whether they're nurse practitioners, PAs, physicians, cannot possibly do all the care that is needed, and frankly should not do all the care that's needed. We're good at a lot of things, but we're not the best at other things. And so in order to do the primary care, the acute care, the chronic care, the end of life care, et cetera, we need teams. And I think that is pretty widely accepted. And I think that there's good emerging evidence of how best to do that. Good teams don't just happen. Teams have to be nurtured, they have to be supported, they have to have standards, and they have to have really strong interpersonal relationships. So pay for primary teams to tell people. And again, I think our take on this was very similar, which was to reallocate. It's not an issue of there's not enough money in the system. There's way more than enough money in the system. The problem is it's not going, in our opinion, it's not necessarily being funneled to the right, in the right places. And so we asked to reallocate and to optimize the healthcare dollar through investments in primary care and prioritize value-based care delivery. And then that goes back to paying for primary care teams. To me, team-based care and value-based care delivery they're really one and the same. They can't be separated in my mind. And so again, I think Jackson in the NASEM report made a very strong argument about why we should pay more for primary care. And I love the primary care as a common good. I have used that many times since we first read it. And I think it's a very powerful statement. So it's kind of a, you get what you pay for scenario, I think. And we're not getting good quality, consistent, sustainable primary care. We do need to pay more for it. And there's a big movement in that. And there are places in this country, there are places like Washington State, Oregon, other places have actually taken to their legislature rules, regulations to say you will over time increase the amount of money that you spend for primary care. Now, is that doable in Texas? We're optimists, so we maybe like to think so. I think the jury's out on that. The trained primary care teams where people live and work really resonates with us. And one of the reasons is, you talk to smaller communities. You talk to Abilene, for example, where you spend a lot of your time, Jackson. And there's like the community colleges there, or even high school. There's high school vocational type training. And a lot of times you see it in smaller communities where there's a connection, there's a connectivity between those training programs and the people that live in that community, the physician offices, clinics, et cetera. So I think that is that's a secret sauce, in my opinion, is to train primary care teams where people live and work, people that know the people that live in their community. I think that's very powerful. And again, we go back to our belief that optimizing the primary care workforce by advancing a team-based approach for the health of all Texans. So I'm going to stop and see, Jackson, if you have any comments about that, if you have any response to my comments.
No, I would just echo the where you started, which was just this alignment between the work that the TPCC has done and NASEM did. I think that it speaks to a great deal that the Texas is almost maybe a concentrated version of some of the dilemmas that are experienced at a national level, not only because of 254 counties, the majority of which are rural and health professional shortage areas, and also because of the underinvestment in primary care that's experienced at a national level seems to be experienced in an acute way in Texas. So the kind of the Texas forms I think an important representation. If we can get it right in Texas, then what a sort of shining star it would be in the rest of the country, and encouragement to Arkansas, Mississippi, Missouri, that this can be done. And so I'm excited about the work of TPCC in saying, yeah, we can drive some of this.
Great. Ankit, next slide, please. And I knew this was going to happen. This conversation is so rich that I'm probably going to run out of time for this. But I think one of the most important and valuable things that your paper did was this implementation framework. Because again, I think all of us can identify what the issues are, but not all of us can identify in such a really thoughtful and logical manner how to implement those things. And I want to touch on a couple of items just to get your sense of it. And if you look at macro and you look at the federal, state, legislative branch policies, laws, funding, well, I would say that there actually is a lot. The Center for Medicare and Medicaid Initiatives, right, with the CPC and CPC Plus, and now Primary Care First. So I feel like there is a fair amount of activity, has been a fair amount of activity on the federal level in those things. And in terms of coalitions and associations, I mean, look at us, the us, TPCC, and then in Washington, the Primary Care Collaborative has done a fabulous job. Our primary care associations, all of them, and Primary Care for America, the new sort of marketing, if you will, campaign to promote primary care. So I feel like there's a lot going on in there. Comments about that?
Yeah, I've got too many screens here. I'm trying to find my mute button to unmute myself. I think that's an accurate observation. I agree that there has been investment to look at a number of different models, and now we know what works. And I think that's where the committee's sentiment was, let's not pilot more projects. Let's now move forward with what we feel confident works in terms of what we fund, how GME works, additional funding in at the research level at NIH. So HRSA, ARC, NIH, those are kind of the legislative and executive levers that were kind of in the purview. Now that we know what's effective, let's legislation and executive action at the agency level to get those things done.
Sure. And, I also think that the other thing that we have to say, and because people do tend to forget it, is in that same category, the Affordable Care Act, what it really has done to improve access to primary care, to health services, behavioral health services, substance use disorder treatment. And we know there's good data, and every day we see new data that what a positive effect it has had, the access has had on individuals and communities. So I think we have to really never forget that important thing. So on the meso level, again, I think from what I know of, there is movement towards things like reducing administrative burden. I think that the federal government would like to see us move much towards value-based payment and value-based care. But doing that, it is not a linear process, right? And there are a lot of challenges associated with it. And certainly smaller practices to move to a value-based care payment model, there are challenges in terms of really gearing up and understanding and having the technology and the systems in place to do that. Thoughts about that?
No, it is delivery models right now. Again, I think there's ample evidence to know where we can generate higher value, and in particular those larger healthcare systems that have the capacity to begin to move towards risk-bearing models. They have a certain responsibility to lead out. Primary care, by virtue of it being just so diverse and so tailored to the various communities in which it exists, this is where it gets a little gray on the micro versus meso, because you've got, how many offices or how big does the network need to be before it's a meso, when we're talking about health system delivery reform. But in that space of delivery transformation, there are some consistencies throughout the very small clinic in Muleshoe or in Pampa and some realities that exist, the Baylor Scott and White system or the Ascension system that's in Texas. So there are some things particularly pertaining to team-based care that apply across the board, and again, using the best models that exist and tailoring them to the community. I think part of the exploration around both delivery reform and team-based care is understanding the community and the community's needs and how to build the primary care team that fits the community. So if you're in Montrose, South Dallas, if you're in Austin, if you're in Gun Barrel, Texas, those are all going to look a little bit different in terms of what the tailored delivery system is going to look like and what that interdisciplinary or interprofessional primary care team is going to look like. And so really building the team around what the needs are of the community you're in is another kind of, I think, key piece of the recommendations.
All care is local, right? Politics are local, and care is local.
Great point.
So
great point.
Yeah, it's really true. I find this next in the meso and the private, under the private category, I find this particularly interesting in private payers. Again, we're not here to denigrate anyone or to speak ill of anyone, but I can tell you, after spending almost 12 years in this space, it is a major challenge to achieve what you talked about earlier, and that is the multi-payer collaborative. And we know from history that is the holy grail, really, of advancing primary care, whether there's a patient-centered medical home or any kind of transformation. We have not had, in this state anyway, much success in managing to convince the private payers, even with the protections that you outlined, that this is something that they need to engage in. And you look, again, the federal level, some states were able to do it in the CMMI and CPC Plus and things like that. So that, if you ask me what for here has been one of the most challenging aspects, it has been that. And I don't know that you have, you're welcome to comment on it. If you have any secrets, now is the time to share them, not keep them.
well, I think that's why these conversations really have such power, is because these are the conversations that I think, and the conversations at TPCC are the conversations that stimulate the unified voice among those who are on the delivery side to summon our state government to call payers to a certain degree of accountability. There is we know that it's best for everyone to have access to primary care, and for primary care to look and operate a certain way. And while the state legislature or the governor may be initially reluctant to take on any of this as an initial pet project, we have just our Department of State Health Services, may be willing to kind of listen deeply to how they might be able to enforce some payer alignment in Texas, and it might be, as we build momentum later on, building legislation to sort of galvanize this going forward, but preliminarily, Department of State Health Services, and I think that's where, so I think about your experience, and those who have been equally involved in TMA could be our partners in moving this forward.
Absolutely. Great. There's so much more we could talk about, but we are at time so that we can have time for questions and answers. And I know that there are going to be quite a bit. So thank you very, very much, Jackson, for those responses.
So again, thank you so much. And again, Jackson as well, for a wonderful presentation and the discussion. And I really like this from a pragmatic perspective. I'm always looking for those practical applications. And I think that's where the focus has been, both with the NASEM report and the implementation framework, but even Sue, your exchange on how do we apply this in Texas. So I already see several questions. For those of you who joined us lately in the webinar, please use the Q&A option on the bottom of your screen to send in your questions. I have the honor to facilitate the discussion and the Q&A section for today's session. And I'm going to begin with one that I mistakenly indicated that was answered. Still getting used to the world of Zoom as a facilitator. So I think this question is from Dr. Carlos Jain. What can we do in Texas to promote the creation of a Secretary's Council on Primary Care? Sue, I would love to hear your take, but I'll just drop in a teaser for our next webinar, which is on powering primary care advocacy that you'll hear about in a few minutes before we sign off. But Sue, would love to hear your take as well as Jackson on some practical steps we could take within and outside the primary care consortium.
Thank you, Ankit. And again, being the eternal optimist that I am, that we all are, I think. Some of us are dangerous optimists. I just saw one comment in the comment. I think the pieces are there. I think the data is there. The pieces are there for us to be able to bring forward a framework for such a commission. And I think, we have people like Dr. Hyan, who is one of the giants really in the PCMH primary care movement. We have people like Tom Banning, who I think is on the call, and he has tremendous influence. And so I think we need to find the right ears, if you will. We need to find the right sympathetic ears. And I think we can do that. I do think we can do that. And again, COVID, better, worse, bad, whatever. I do think it has really shone a bright light on primary care and has made people wake up and go, wow, okay, there really is a problem here. So I think we can do it. I think we have to find the right audience.
I agree. I'm one of the things that I'm curious about is what the analog to that is at the state level, but at the national level, from what I understand, there has been some support from the Office of the Assistant Secretary of Health around that council. But it doesn't yet have the secretary's blessing. So there's a little bit of positive movement, some early positive signs from the NASEM report, but I don't think we're quite across the finish line at that secretary level yet. But making progress.
Wonderful.
Yeah, and I think think about people like Dr. Hellerstedt, the Department of State Health Service Commissioner. He's a pediatrician by training, right? People like David Lakey, who are out there who really do understand it. So I think it's people, maybe not so much legislators at this, but it's sort of getting the thought leaders and folks from Dell. I see Lisa Kirsch has been on, folks like that really can help move the needle, that are in the right position. I feel like it can be done. I really do.
Wonderful. Thank you both, Sue and Jackson. I'll take the next question. So if one of the major keys to transforming our sick care system is payment reform, and we talked at length both in the TPCC perspective, but really looking at even the objective one within the NASEM report, and we really break it down into some actions that need to be taken. But I think there is an additional context in this question that would love to hear your thoughts on, is how, knowing that the main motivation is at times for the commercial insurances on making money for the company, and on the public insurance perspective is to saving money, and we are caught in between that dilemma, right in the center of it. How do we go about convincing? I think it, again, at the heart of it is the advocacy, and probably what I would lean on, Jackson, is your statement that primary care is a common good. But again, practically, how do we get over that finish line? Jackson, your take.
Well, yeah, one of the, as I mentioned in the talk, that how accountability is so key, particularly, United States is doing this different than any other country in this public-private kind of collaborative. I think that by framing primary care as a common good, it does give us language for why public policy has to be there, how, you can't ensure a common good without public policy. And I do think that the policy window notion that we have this moment in time, as Sue referred to before, when everyone is acutely aware of the weak points in the healthcare and public health system because of the pandemic, we will have a period of time where we can make lots of progress in that policy window. So I don't think that, as I mentioned, I don't think that the marketplace is going to drive this. I think there has to be policy. Policy requires, like you mentioned, Ankit, advocacy, and I think that the fields are ripe for that advocacy in the pandemic, post-pandemic moment.
Wonderful. So anything
Sure,
you
and
want-
I agree with everything Jackson said. I think we do have sort of a unique opportunity in Texas that is to what can we influence, right? What can the state really influence in terms of payment for healthcare? And that is actually somewhat limited, it turns out. However, having said that, we do have the employee retirement system of Texas, teacher retirement system of Texas, and Medicaid really under the aegis of the state. And the state, if they wanted to, could say, and I think should say, all right, we're going to do a pilot program on value-based payment. And wouldn't it be great if the ears of the private payers sort of perked up and we're like, well, we want to be part of that too. I think there's probably a lot of wisdom that we could glean from the other states that have been in part of CPC Plus, where they actually did have commercial payers together. How did they get them there? And I think that's one thing that we really haven't tapped. So again, my optimist is showing, but that's me. I think it can be done.
Wonderful. I feel positive. Thank you both. I think the next question, which I'm very interested and curious to hear your thoughts on, is how do we bring employers? I think that's been a discussion for us even within the consortium, as part of frontiers to cross. How do we bring employers into this discussion to move the needle in this direction? Again, the heart of it is that we often talk about is payment reform, and knowing the supply chain of that component of the system. Employers have both skin in the game, but also influence. So I would love to hear your thoughts.
Sue, you want to take this one first?
Sure. No, it's interesting. And I was going to mention this. I was going to refer to this in that macro discussion, that because one of the bullet points is corporations. And it's pretty clear that if you will, the sleeping giant is sort of awakening. And that is, historically, large corporations really looked at primary care in particular as a cost center, right? It's like, oh, I've got to pay for, or healthcare in general, primary care in particular. I've got to write a check for this. And I do think that through a lot of different mechanisms, folks in Houston with a business group on health there, the folks in Dallas, the Pacific business group on health, and there's been a lot of activity in TAFP, really have to give a nod out to for a lot of the activity they've done to now, I think, enlightened corporations anyway, are beginning to see that no, paying for primary care in particular is an investment. It's an investment in the health of our employees. And so how do you spread that? And there's an educational component to it, but I think it's a very positive sign that many corporations are starting to wake up and go, yeah, okay, we do need to invest in this. And they may be waiving copays for primary care or things like that. So, or for screening, whatever. So I think there's positive movement on that end.
I think that's right on. And it seems to me that the moment in which we have this rapid expansion of telehealth options could play into this, as well as we create new opportunities for employees to seek primary care services without missing time at work or much time at work to take a half day to come into primary care. We can use this, again, this kind of moment of opportunity to share through certain innovations, the value add of regular access to primary care, and then kind of grow it from there. I agree that the message has to be changed from these kind of annual cycles of what's my immediate ROI to a more long-term investment. If you invest now in primary care, then your costs, 5 years from now are going to be, I think that we're kind of early on those kind of projections, but I think that those economic analyses are forthcoming, where we'll be able to really make a clear case with dollars and cents attached to them to large employers as to the downstream value of primary care investment today.
Wonderful. Thank you both. Certainly some work to do in the area, but I really like your practical application and strategies that should be considered, again, for stakeholders across the spectrum. So thank you. I think the next question that we have is, I'll try to summarize this, is on the team-based care and advancing population health management. As we seek to tap into additional dollars outside of the transactional nature or fee for service, how can we, rather than just adding for more dollars and adding to the frenzy, how can can we look at the current programs such as MSSP, the shared savings programs and rewards for cost cutting? And since there is an hesitancy as a result of that push, how can we influence that change in mindset to begin with, and then of course the system?
Is the question particularly around funding interprofessional primary care teams, or is it about the design of the teams themselves, or maybe it's both?
I think it's both, but the heart of it is like there is this perception, or the if I may say, as I'm reading the question, I think it's more about that naturally the outcome becomes is about cost cutting and hesitancy as a result of that in terms of participation. So as we seek to advance many of the strategies, what we need to do differently is rather the way I would interpret the question.
The paper itself, the report itself, tries to change the paradigm away from those sort of quick cost-cutting strategies towards long-term investments, and identifying that that the fee-for-service model, and specifically dollars going to medical clinicians, is not going to lead to the population health outcomes and health equity that society wants to see. And so, in terms of pragmatic ways right now, as we are building, value-based contracts, I do think that action items that around prospective funding of interprofessional care teams, I think going into negotiations, recognizing that there has to be upfront funding for a change in the model of design in order to get the outcomes that both the providers and the payers want to see. I think that's part of how to maybe begin to make this change, is that prospective upfront funding for change in design. Sue?
Sure, and this will be a little tease for our next webinar too, because Chris Kohler, who's going to be our second webinar speaker, we had a conversation with him last week, and he used to be the Rhode Island Health Commissioner. And one of the things that he said, and is so true, we have to be realistic about timelines. And we've known that from the PCMH world, where, maybe the payer said, in 2 years, you have to show XYZ return. Well, we all know that transformation is not a linear process, right? It's kind of fits and starts, and people can get fatigued, et cetera, et cetera. And so I think we have to be honest and realistic about the timeline expectations for all of these things, whether it's value-based payment, whether it's MSSP, building teams. The timeline is longer than I think the prevailing folks that are interested would like it to be, including us, but that's just reality. So we just got to be honest when we have these conversations, I think.
Again, thank you so much. I want to be cognizant and respectful of both of your times and for everyone who has joined us today. We do have a couple of housekeeping announcements and notes, but before I transition, I just want to share my admiration and gratitude to you both, and particularly Jackson, for really making the 400-page report more consumable and actionable for us here in Texas. And we are certainly looking to implement a lot of that framework recommendations through our work in leading the consortium. I do also want to recognize and that there were a few questions in our Q&A that we have not gotten to, but I think at the heart of it, I want to just on behalf of the group respond to those. Is that part of some of the barriers that we have within the primary care landscape as we talk about today? I think that's really at the heart of developing the implementation framework, that unless and until we can't really talk about the root causes and fundamental changes at the systems level, which is what the implementation framework seeks to do, we cannot get to that basics of day-to-day and really looking at that shift in mindsets about the role of primary care and its connection to the pursuit of the quadruple aim. But this is certainly feedback that we at the consortium don't take for granted, and we will be thinking about the questions that we have not gotten to answer today and deliberate on, and think as part of our charge as we continue to move forward in our work and barriers that we have to overcome on behalf of the collective. So with that, I'm briefly going to share my screen again and do my part of the closeout. first and foremost, as you can see in my background, and we are very excited for reconvening the consortium for our annual TPCC summit. If you haven't joined any of our previous summits, you definitely don't want to miss the upcoming one on October 14th and 15th. In light of the pandemic, we will be convening in a remote virtual environment, and hoping that all of you have joined us today. We'll get to see you virtual in about a month. And those of you who have not joined us but may watch this recording, we hope that they can take the advantage of the opportunity. Also, as we have shared a few minutes earlier, and as Sue pointed out, we are very excited, and I think that's at the heart of it, is we really need to advocate for primary care and raise our collective voices for that larger change. And couldn't have thought and asked for an amazing lineup or speakers that we have with our friends at Milberg Memorial Fund, and really their work, what they have done for that primary care advocacy pursuit nationally, as well as some realistic practical work that they have done to move the needle in other states, and we'll be learning from both Chris Kohler and Dr. Lisa Watkins. Also,
and Ankit, it's Jackson. Chris was another author on the NASEM paper, so all the questions that were hard questions that I couldn't answer, ask him again to Chris. He'll have the answer.
Absolutely, Jackson. Thanks.
He's a magnificent person. I'm so glad y'all are having him on.
Wonderful. Thank you so much. That definitely is encouraging. As we have communicated in the past and the announcements to date as far as a webinar, this is all part of our continued commitment in making primary care primary in Texas. So if you haven't had a chance, apart from the new webinar series, an exciting summit, other data resource that we have for all of 254 counties in Texas, please visit our new and updated website of the Texas Primary Care Consortium. Our vision and hope is that we will continue to leverage our resources to make this as your go-to resource on everything primary care in Texas. And of course, we will invite your ideas, feedback, and considerations for our work moving forward. We cannot do this ourselves. And as I said in the beginning, we truly are thankful for our partners, but you and your organizations could be part of this movement as well. So we hope you will consider exploring, and please feel free to send me or Sue Bornstein a note on how we can engage you and your organization in this work of advancing primary care and health of all Texans. To continue to know for new activities, announcements, or projects and outcomes from TPCC, please subscribe to our newsletter. And of course, Sue and I have the honors to do some amazing work and really speak to the pursuit of Texas Primary Care Consortium, but both of us would be remiss to not recognize our amazing team that helps us do this work every single day. So again, it takes a village, and we are just proud of the movement and journey we have been in, and we hope that we can continue to make strides in the right direction, and we need your continued support. So thank you for joining us today. Hope you found this helpful. As always, open to feedback, ideas, and suggestions as we continue moving forward in this journey. With that, be safe, be healthy, and continue to do what you do to improve the health of all Texans. Thank you.